Hello, I am Dr. Sarfraz Majid, diabetologist and physician. I practice in Kolkata, in south part of Kolkata. Today, I'll be discussing a very important topic that is very much related with diabetes, which is very much seen in diabetic patients, especially among like those who have poorly controlled diabetes with genital tract infections. So there is a lady around 68-year-old who returns to a clinic for a follow-up with a 3-month visit. After 3 months of follow-up visit, who has initiated empagliflozin 10 milligram for her diabetes. Her glucose level improved, but she complains of vaginal pruritus and is worried that she has a yeast infections, fungal infection that we say in private part. So we diagnosed a vulvovaginal candidiasis in this patient and prescribes a single dose of fluconazole 150 milligram weekly for 4 weeks. After reviewing her laboratory test results, it was noticed that she started empagliflozin. Her HbA1c was improved slightly from 8.9 to 8.2, but is still not where it needs to be. Her EGFR is 69 ml per minute per 1.73 meters per d square. As we all know that sodium glucose co-transport inhibitors are an increasingly important and oral medication class of type 2 diabetes drugs, with the use of climbing dramatically in recent years because of having a lot of advantage. So they result in a broadly similar amount of glucose lowering compared with other oral agents, but can also reduce blood pressures. There's a result in moderate weight loss, especially the visceral fat. There's also reduction in slight uric acid also it has been found. In addition to their glucose lowering effect, it has a large scale clinical trials have demonstrated that there's a reduction in cardiovascular and renal outcome in high risk group with type 2 diabetes, as well as benefit in patient with heart failure, whether or not they have any type 2 diabetes. Even now, it has been also used in among non-diabetic patients as an heart failure treatment, as an anti-heart failure treatment. So empagliflozin is a very good drug and it provides a very good results. And not only it reduces blood glucose, but it also has a lot of extra advantages. As I discussed, like reduction in blood pressures, uric acids, it also improves comorbidities like cardiovascular and renal outcomes, and there's improvement in ejection fraction as well. Thus, SGLT2 inhibitor reduces hyperglycemia in people with diabetes by increasing urinary excretion of glucose. So this is the mechanism. What it does generally, glucose are there in blood. It gets filtered into kidney, and we call it ultrafiltrate. And this ultrafiltrate contains glucose and other important components which get reabsorbed in the kidney itself. So empagliflozin, what it does, it blocks a receptor, SGLT2 receptors, and does not allow glucose to be reabsorbed from ultrafiltrate and let it get excreted into the kidney, into the urine. So patients who are taking empagliflozin, there'll be a reduction in reabsorption of glucose from ultrafiltrate, and they'll be excreted into the urine. So patients who are taking empagliflozin will have glucose in the urine. If you test for glucose in the urine, you will find it very highly positive. So this induces glycosuria, increases the risk of, and as a result, that also increases the risk of genital infections because of presence of glucose in urine. And both clinical trials and observational studies has demonstrated there's almost 2.5 to 6-fold increase in genital infection in people using SGLT2 inhibitors compared to controls. Well, this is symptomatic initially. I mean, majority of the time, it subsides of its own. And once the blood glucose comes under control, these things also weans off. So the development of genital infections is more common with SGLT2 inhibitors. Overall incidence in clinical trials is around 4 to 6% compared to other oral hypoglycemic agent. As I told you that because of the excretion of glucose in urine, and it can dissuade patients from persisting with treatment. Though it's a very good drug, sometimes patients do not want to take this because of the frequent fungal infections, which has been seen with SGLT2 inhibitors like empagliflozin. A number of factors have been shown to be associated with risk of genital infection in the general population, in particular female sex and diabetes, especially when glycemic control is poor. So one of the major concern for genital infection is poor glycemic control, number one. Number two, sometimes because of unhygienic patient do not take care of properly of their private part, and that lead also into fungal infections. So in order to minimize or reduce this fungal infection, a combination drugs where SGLT inhibitors combined with DPP4 inhibitors offer a suitable component in the strategy to achieve target HbA1c without increasing of hypoglycemia and weight gain with improvement in overall lipid profile. So no doubt SGLT inhibitor is a very good drug and it provides very good results, which has a lot of benefit. But sometimes because of the fungal infections or recurrent urinary tract infection, it may not be feasible or possible to continue with the drugs. So, but we still want to use it. So the better way of using it is in combination with DPP4 inhibitors like linagliptin, vildagliptin, or sitagliptin. And there, a single drug combination also comes with of SGLT inhibitors with DPP4 inhibitors like empagliflozin with linagliptin. This is a very good drugs, and it gives a very good combination, and it has been found that because two drugs are acting together, the blood glucose reduction it becomes more efficient without causing much of hypoglycemia. And also has been seen that DPP4 takes 50% of the burden of glucose reductions, and so there's a less reduction of glucose into the urine, and there's a chances of reduction in the incidence of genital infection associated with SGLT inhibitor has been reported. So we can see that just by combining with DPP4 inhibitors, we are continue to provide the benefit of SGLT inhibitors, and we are minimizing the chances of UTI and fungal infection that is caused due to SGLT inhibitors just by combining DPP4 inhibitors. So it is a win-win situations without any major adverse event. So in clinical practice also, the risk of genital urinary tract infection may be barrier preventing patient from receiving or continuing a potentially life-saving therapy. In addition to local hygiene consultation on how to prevent UTI and identifying combination therapy that limits the risk of adverse event in an interesting strategy. So the putative mechanism whereby DPP4 inhibitor may moderate SGLT inhibitor associated risk deserves some comments. By far, the most straightforward explanation is that, as I told you, a combination reduces the glycemia and glycosuria more than SGLT alone, and thereby resulting in protection from genital tract infections. So DPP4 activity is present within some yeast, molds, and bacteria, and it inhibits may directly modify microorganism function. These highly speculative and sophisticated hypotheses need to be tested experimentally. In clinical practice also, we have seen a combination therapy of DPP inhibitors with SGLT inhibitors gives better outcome compared to monotherapy, whether it's combined with monotherapy because of with SGLT inhibitors or DPP4 inhibitors. And theoretically, it might appear that a combination drugs, two drugs may cause more chances of hypoglycemia, but it is not like that. The pathophysiology behind diabetes is been divided into eight parts. We call it ominous octet. This ominous octet, that means there is a 8 pathophysiology are there, 8 mechanisms of pathophysiologies are there that lead into diabetes. So a combination of SGLT inhibitors and DPP4 inhibitors almost cover up 6 to 7 pathophysiology. So the different pathophysiology is being taken care by the combination of these two drugs, and as a result, it has been found that this does not cause hypoglycemia or any adverse event, but on the contrary, it provides better outcome by addressing the mechanism, pathology behind the diabetes. And as a result, there is a better control with a lesser side effect. So it has been found that the monotherapy only with empagliflozin gives a lesser control of blood glucose with more chances of genital infection or fungal infection. But when the same patient is given DPP4 inhibitors combination like linagliptin with empagliflozin, and it is found that there is a better control of blood glucose, better outcome, and lesser chances of excretion of glucose in urine, and there is less genital infection and urinary tract infections. So the putative mechanisms whereby DPP4 may moderate SGLT inhibitor associated urinary tract infection deserve some comments. As I was telling you that the combination therapy reduces glycemia and glycosuria more than SGLT inhibitors alone, thereby resulting in protection from genital tract infections. And DPP4 activity is present with some within some yeast, molds, and bacteria, and it inhibits may directly modify microorganism functions. These highly speculative and sophisticated hypotheses need to be tested experimentally. So we can see a combination drugs provides better outcome and lesser side effects compared to monotherapy with empagliflozin. So a combination of empagliflozin with linagliptin will give better results, better control of blood glucose with lesser chances of hypoglycemia and lesser chances of infections compared to monotherapy with empagliflozin. So in this patient who is responding well with empagliflozin and blood sugars are coming down slowly, if we replace this empagliflozin in this lady with a combination drug of empagliflozin with linagliptin, so it will not only provide the better outcome to the patient, but it will also help to minimize her genital infections and urinary tract infection, which she's complaining of. So in my suggestion, you replace a monotherapy of empagliflozin with a combination therapy of DPP-4 with SGLT2 inhibitors, and that will give a better results and lesser side effects to the patient. Thank you.